Welcome to Barcelona, one of Europe's biggest cities and hub for sport, art and now urology. As the 34th annual EAU Congress gets underway, the top minds in urological research and clinical excellence are coming together to discover the very latest science and get to grips with the most up-to-date guidelines and techniques. We're here all week to make sure you don't miss a thing. It's EAU TV. Welcome back to EAU TV. We're back in the Fira Gran Via as the 34th annual EAU Congress enters its third day. Well, the weather has been fantastic, the food has been delicious, but what we're most excited about is what's going on in here. Today's show will be bringing you all sorts of great news and views and the latest insights from the world of urology, so don't go away.
The new is with Camina that for the intermediate risk group population, we need an individualized therapeutic approach.
We want to create an institution which can deliver services at an affordable cost to every member of the society.
Probably combination therapy is going to replace monotherapy in metastatic kidney cancer in first line.
The patient has every option, every modern treatment which is available worldwide.
From solid evidence, I think we have learned that it's safe to treat with atezolizumab patients with impaired renal function, with autoimmune disease, even with ECOG performance status.
We want to continue with all developments which we expect in this field, connecting doctors for consultations, planning research, planning training and education, planning guidelines.
Our study focuses on the FGFR3 mutation versus FGFR3 expression in radical cystectomy.
We are trying to develop a new way to treat prostate cancer based on the armamentarium we have today. We just remodulate the armamentarium and trying to find a better objective.
First up, let's head to the Euro Auditorium for plenary session 4, focusing on renal cell carcinoma. Euro Auditorium 2 was packed with attendees, eager to listen to the debate on one of this year's hot topics. The session, entitled Cytoreductive Nephrectomy, Does Carmina Change Everything?, brought together two experts to discuss the findings of the trial. Marcus, you've just come out of the session that you were moderating. Tell us very quickly, for anyone that doesn't know, what the Carmina trial actually is.
We had a lot of data from retrospective trials that demonstrated that patients with simultaneous metastatic disease at the time of diagnosis of renal cell cancer derived a clinical benefit from nephrectomy, followed by systemic treatment in the majority of cases. All these trials were retrospective data and were highly impacted by unidentified biases inherent in these trials. So Camina tried to answer this question whether patients derive a clinical benefit according to an individual risk profile on a prospective basis.
Was there a consensus that Carmina changes everything?
Camina demonstrated that systemic treatment alone is superior to cytoreductive nephrectomy or a surgical approach when this patient population is addressed belonging to the poor risk group. But this is also a practice we have followed during the last year already. What's new is Camina demonstrated that we can lose the fear of subjecting patients to a systemic TKI-based therapy who subsequently undergo an interruption of this treatment due to an experience published by Tom Pauls that this might hamper the prognosis of the patients. Camina demonstrates that this is not the case. But the new is with Camina that for the intermediate risk group population, we need an individualized therapeutic approach that includes, on the one hand, metastazectomy, so resection of metastases, and on the other hand, for patients with a higher metastatic burden, systemic treatment upfront, nephrectomy perhaps.
Marcus, thank you so much for joining us.
Thank you very much.
Well, some fascinating work there, and we'll have more of EAU 19's RCC coverage shortly. But first, let's head over to India and the Asian Institute of Nephrology and Urology, which is providing cutting-edge services to a diverse and large population.
The central idea of creating Asian Institute of Nephrology and Urology is to create an institution which can deliver high quality services in fields of urology and nephrology. These things were restricted only to some corporate hospitals till now. We want to create an institution which can deliver these services at an affordable cost to every member of the society. Not only this, we want to create an institution for training future generation of urologists which will be useful to this society in future. To deliver these high quality services, you require committed team members. In our institution, the team members are not only professionals working for it, but also partners of the institution. This increases their responsibility. The investment involved is going to be huge in creating these institutions, but the targets can be met with easily by these committed team members. A single specialty institution with high volumes and a committed team members looking after various subspecialties of urology will be an ideal ground for a younger urologist to get trained. We are successful in creating an institution of this kind for future generation of urologists.
We have invested 40 crores in Asian Institute of Nephrology and Urology, Hyderabad. Our core investment was in physical infrastructure, including the development of a 100-seater learning center, medical equipment, development of protocols and quality assurances, and a very good surgical team. After 3 years, we found the deficiency of a robotic surgical system. Then we acquired Da Vinci S1 surgical system. This is one of the few single specialty hospitals in the world to have this system. We started Asian Institute of Nephrology and Urology with 2 senior urologists and 2 junior urologists. Over time, as the work increased, we had to recruit more urologists, and many people were interested to join the institute because of the good work being done and also a good academic activity here. They were not only getting the monthly salary, but there was a variable income depending on the performance of the institute.
We at Asian Institute of Nephrology and Urology were always keen on building a competent team which could deliver all the subspecialty related services in urology. We always were looking to recruit youngsters who had a long-term commitment towards the institute and thereby giving them the liberty to subspecialize in the field of their interest. In today's world of modern medicine, subspecialization is the way forward. We at Asian Institute of Nephrology and Urology have always believed firmly in subspecialization. We have put a team together in various subspecialties like laparoscopic urology, robotic urology, endourology, and andrology, to name a few. And this has allowed us to train our younger generation in a more effective manner.
We are working in a highly specialized area of nephrology and urology in a nephrology-urology oriented hospital, where for our end-stage renal disease patients, we need help of urologists in creating arteriovenous fistulas. We also do a large number of kidney transplantations with usually related donors, and our urologists have been more than helpful in doing successfully the kidney transplantation as well as post-kidney transplant follow-up work.
Teamwork is the ability to work towards a common vision. It is a fuel that enables common people to attain uncommon results. At Asian Institute of Nephrology and Urology, we work as a team, and it has got many advantages. One can focus on the subspecialty of your own interest. Your patient's care is doubled, as your colleagues are involved in the decision making, intra-op and post-operative care to the patient. Your experience and expertise of your colleagues are utilized to give an overall better outcome to the patient.
Asian Institute of Nephrology and Urology is working towards creating a similar centers of excellence in future, both in treating the disease and training the younger urologists. The basic motto of team members being partners of the institution will remain the same.
With a world-class panel, Sunday's Thematic Session 1 discussed major topics in immunotherapy in genitourinary oncology, with a particular focus on whether single agents can be replaced with combination therapies.
Kidney cancer is an immunogenic cancer. We know that. Kidney cancer tends to be infiltrated by immune cells. Kidney cancer also in the past has responded to immunotherapy strategies like high doses of interleukin-2. And kidney cancer also, when it's treated with the classical anti-angiogenics, the immune system gets modulated. So we get more infiltration of immune cells, and also we get an upregulation of PD-L1. I think that tells me there is a window of opportunity. I got a tumor that has to do with the immune system. I got a treatment that we've been utilizing for 15 years that modulates the immune system. So why not taking advantage of that and utilize immunotherapy, sequence or combine with tyrosine kinase inhibitors, with anti-angiogenics. Based on the data that we've been discussing and that have been recently published, I think we're ready to say that probably combination therapy is going to replace monotherapy in metastatic kidney cancer in first line. I think only a small number of patients will be excluded from this treatment option in the near future.
We want to create an institution which can deliver services at an affordable cost to every member of the society.
The patient has every option, every modern treatment which is available worldwide.
Our vision is basically to serve poor people at an international standard and at an affordable cost with ethics and values.
The Wesley offers really the latest technologies and procedures across the range of medical and surgical disciplines.
Our Department of Urology and Uro-Oncology at Albertine Hospital in Hamburg is one of the most modern departments of northern Germany.
Our philosophy is to place the patients first. It's not just a slogan, it's important to all of us.
Great work, and we hope to continue to see new therapies coming through for renal cell carcinoma. Now let's go over to the Paracelsus Medical University in Salzburg, which is using cutting-edge technology.
Our urological department has grown not only in dimension and in numbers, it has grown also in the possibilities we have due to technology. We have the big advantage that we are working in a system which gives to the patient every single possibility. We treat the patient from the diagnosis at the outpatient department and treat the patient surgically, and if the patient needs systemic therapy, it's offered in one institution, which is our urological department. So the patient has everything in this building and has every option, every modern treatment which is available worldwide.
We are the central hospital of the state in Salzburg, and therefore we are the center of excellence for urologic surgery. A big change was the implementation of the Da Vinci robot in our field, but also the immunotherapy in metastatic disease, and all the patients benefit from these advances.
We can offer nearly every operation as a minimal invasive treatment. We can offer mini PCNL, which means that we can remove stones from the kidney with a very small instrument, so there is much less bleeding. We can offer our patients the newest instruments for rear surgery for kidney stones. We are the only clinic in Austria which can do bipolar enucleation of the prostate, and we have very promising results of this new technique. Since more than a year, we can offer the Da Vinci prostatectomy for our patients. This was an huge investment for our clinic, and so we are very happy that we can do this. Patients can start again their daily life much quicker compared to open surgery. For us surgeons, there is also a big advantage because we can sit and we have a very good vision, 40 times magnification of the field. So we can spur the nerves now because we can see them. So there are a lot of advantages for our patients. We are for the third time EBU certified center. That means we are very much interested in teaching residents. We have 7 residents at the moment. We are a very small team, so every resident can come to the operation room. When they have finished their resident program, they can do most of the operations they needed for urology.
Our residents can train at the Bellevue trainer for laparoscopic surgery. They can do training at the robotic console, the Da Vinci console, and they can also do open cadaver studies.
The Paracelsus Private Medical University is strongly connected to our clinic. It's a private university. There are a lot of cooperations between the clinical departments and the departments like anatomy and physiology at the private medical university. It is our mission to be involved in several different projects. We have actually more than 15 clinical and research projects going on.
We are comparing open laparoscopic and Da Vinci surgery, and also at the medical trials we are doing a lot of research.
We have here a small laboratory that is for urology, for a routine analysis, but we also have a lot of clinical trials that we conduct here, sponsored clinical trials. We have now over 10 open trials, and we also help our doctors in their own academic studies. We are specialized also in andrology, and we give courses to our colleagues. We also support our young doctors here with their own academic works, and we have students and support them in their bachelor thesis.
We are mainly involved in research in urothelial cancer and prostate cancer. We have also the possibility to cooperate with our private university. We have a lab where we are cooperating regularly and mainly in neurourology.
We are collaborating since about 6-7 years with the Department of Urology with Professor Lusuardi, specifically on the topic of spinal cord injury and bladder function. We are trying to regenerate the spinal cord, also in order to regain function of bladder, because this is essential for patients' quality of life.
The Institute of Molecular Regenerative Medicine and the Urology of the Salzburger Landeskliniken work together on electrical stimulation of peripheral nerves that can improve bladder function after spinal cord injury. Furthermore, we look on medications and molecules that are potential candidates for improving bladder function. And finally, cell-based therapies are currently looked at to see how these cells or vesicles might improve bladder function and also the structure of spinal cord injury patients in the future.
I think this collaboration that we have with the Department of Urology is essential for both partners. We are preparing the basic science and preclinical science, but we need the clinical partners to really translate it, and vice versa. Ideas that are generated in the Department of Urology, they of course go back to the lab, and we are testing these ideas. So it's a win-win situation.
Time now for our Trials on Trial feature, where we let 2 experts quiz a presenter. Today, Professor Axel Merseburger is discussing the SOUL trial.
SAUL is the largest trial on immunotherapy treated patients with atezolizumab in more than 1,000 patients worldwide in a randomized trial. The endpoint was safety. Secondary endpoints were overall survival, progression-free survival, and duration of response. This resulted in 8.7 months overall survival, which is comparable to pivotal trials recently published.
Axel, what do you think that SAUL trial really adds to InVigor outcomes?
In Vigor, we have those clinical trial situation. We could not include patients with impaired renal function. We could not include patients with autoimmune disease or patients with a renal function problem. So here in SAUL, we could include all of those, and it adds evidence in this real-world situation, the patients we see every day. Also, we had 5% patients with not urothelial carcinoma, which were included.
In the EU, we have now 3 checkpoint inhibitors approved, like pembrolizumab, atezolizumab, and nivolumab. Some target the PD-1 axis, and some target, like atezo, and then the SAUL trial, the PD-L1 axis. Do you think that this makes any difference?
Looking at those overlying overall survival curves, they were all like matching. So I think it's no different. They all work, they all hopefully deliver a plateau over the years. And when looking in the InVigor-like 211 population, this is almost exactly the number we have seen with Keynote 45 trial. It was 10 months overall survival. So I think this is consistent, considering that this is a very large trial with more than 1,000 patients randomized.
Looking in detail in the SAUL trial outcomes, do you think that immuno-oncology is really prepared for treating performance status to patients?
We didn't randomize for best supportive care versus atezolizumab. So we see that it's safe. This is a primary endpoint, but we cannot draw any conclusion on the overall survival versus, for example, best supportive care.
As SAUL is an observational study, it's like a window of opportunity to include patients with different risk groups and subcategories like renal impairment. What do you think will we learn from the subpopulation, and will there be subpopulations you would not treat in the clinical practice based on data derived from SAUL?
So from SAUL, solid evidence. I think we have learned that it's safe to treat with atezolizumab patients with impaired renal function, with autoimmune disease, even with ECOG performance status. I think it is a safe treatment for all subgroups. However, with regards to efficacy, this, especially in the ECOG performance status 2, is under evaluation. We will have to wait further data. More data is to come. More data is submitted to next conferences, so we have a lot more discussion on SAUL, on atezolizumab in advanced bladder cancer.
EuroGen is one of the 24 European reference networks that are approved and funded by the EU. Now in its second year, I'm delighted to be joined by the coordinator, Professor Wout Feits. Wout, thank you so much for joining us. For anyone that's not familiar with EuroGen, could you just summarise very quickly what it is?
Sure. It's a huge European program which connects different networks and connects also different hospitals over the European countries. Currently, EuroGen involves 40 hospitals of 14 member states, and we expect this year to expand to the whole European Communion.
We spoke at EAU last year, we spoke to the previous coordinator. What's been happening in the last 12 months since we spoke to you?
Well, thanks to the developments of the Brexit, which we have to mention shortly, I think the coordinatorship has moved to Radboud University Hospital in Nijmegen, Netherlands. And so we want to continue with the all developments which we expect in this field, connecting doctors for consultations, planning research, planning training and education, planning guidelines. So a lot is happening actually.
And what would you say is your main focus for the next 12 months?
The main focus will be the extension of the networks by affiliated partners who are appointed by the member states. And there will be a new call for new members who can join the whole network in their full perspectives.
And what is EuroGen's involvement with the EU Protect programme?
Well, the EU Protect program will be launched this year, and within the EU Protect program, it's shown how the citizens are protected by the European organizations. Health is an important issue in this. For urology, we have 3 different work streams, so from pediatric to functional urology and rare urological cancers. So actually the whole spectrum of the disease areas are covered, currently in 16 disease areas, with all coordinators and teams to work and improve the care for the patients.
What would you say is your vision for what you'd like EuroGen to achieve in the future?
I think it will be the main goal in improving the care for patients with rare diseases or very complex conditions, and help their doctors by peer help and trust and sharing the knowledge and developing new guidelines, new clinical decision tools, so that we can improve the care in a lifelong perspective.
Well, Wout, I know you have a website if anybody wants any further information that they can visit, but thank you so much for joining us.
Thank you.
It's time now to take our final look at the top posters here at the annual EAU Congress. And now we're going to be hearing from the author of the best poster in oncology.
I'm Laura Mertens. I'm a urology resident at the Netherlands Cancer Institute. Our study focuses on the FGFR3 mutation versus FGFR3 expression in radical cystectomy. It's a multi-center, multi-laboratory study performed at 9 different hospitals, and we analyzed 1,000 patients who underwent cystectomy for invasive bladder cancer. Our most important finding is that the FGFR3 mutation has favorable prognostic impact regardless of FGFR3 expression. And on the other hand, FGFR3 expression has no prognostic impact in wild-type tumors. I think this study is important because it suggests that the FGFR3 mutation is the key to identify patients for anti-FGFR3 bladder cancer treatment. I'm very happy we won this award, and it's a great boost to continue our research on targeted therapies for bladder cancer.
The role of imaging in prostate cancer is ever changing, and that was the subject of a discussion earlier today. And to carry on that debate, I'm delighted to have the 2 participants here with us now. Declan, could you just start by telling us what are the recent changes in the MRI pathway been?
Well, this meeting has been dominated by changes in our approach to early prostate cancer, specifically with the way we use MRI scanning. And in our session this morning, we particularly focused on the role of MRI in selecting patients for focal therapy in particular. But it flows off the back of a wider conversation about MRI before patients have a biopsy.
So how important, Rafael, is the selection of patients?
It's essential, and as Declan just said, MRI plays a role that is of utmost importance. As we know it, MRI can pick up lesions within the prostate. That is a situation that we didn't have before. And with that, we're able to improve prostatic biopsies. That means that soft tissue characterization is being improved, and we're able to define the disease at another level.
Would you agree with Rafael, Declan? Is this the way you want things to be going?
It is, and it's exciting that MRI has improved and we can see these small lesions in the prostate. And from a focal therapy point of view, our debate this morning was around patient selection. Who can we safely say you can just have ablation of this particular lesion? We have to rely very heavily on MRI. We have to have great confidence that it's showing us the only important areas of cancer.
Obviously, MRI is very good. We have high sensitivity, high negative predictive values, but we're far from being perfect. Limitations are related to the actual definition of the borders of the index lesions we can pick up in the MRI. So we know what the lesions is there, but we don't know the actual limit. We're sparing tissue, but perhaps we're not sparing as much as we would like to today.
So you're more cautious, Declan?
MRI is good, very good, but it's not perfect, and also that our understanding of the types of technologies, the energies that we use is also not perfect, and also the way in which we monitor these patients is not perfect. My concern is that there's still ongoing uncertainty in all those areas about focal therapy.
Could you address Declan's cautious stance?
I believe he's right. Perhaps in the future we will need to address prostatic microenvironment in order to make the field move forward. That being said, what we have today is, I think, is acceptable in terms of cancer control outcomes. If you compare with the toxicity, you balance the toxicity the patients have after the more radical options.
Declan, let me ask you about follow-up. How important is patient follow-up?
We don't really understand how we can follow these patients up. And I think my summary view on all that is to remind ourselves of what the EAU guidelines have restated at this meeting, which is that focal therapy is an investigational approach for these men. So therefore we should really still make sure men are either in clinical trials or registries, so we can at least gather the data that will help us define how to select the patients, which energies to use, and how to follow them up in the future.
Would you agree with that, Rafael?
I agree that we definitely have to do clinical trials and have these patients do clinical trials, but at the same time we have to open perhaps more our minds towards focal therapy. We are trying to develop a new way to treat prostate cancer based on the armamentarium we have today. We just remodulate the armamentarium and trying to find a better objective.
What would your ambition, hopes moving forward be?
Hopefully we will be able to pick up lesions exactly as they are, treat them with the least possible energy developed into the prostate, and eventually we'll have the possibility of simplified follow-up, standardized follow-up, and keep these patients on the surveillance.
Is that realistic, Declan, in your view?
Yes, it is, and I think it's an exciting era we're in now, and I think focal therapy certainly has a role in our future management. I think we just need to be cautious and make sure we do it right.
Well, we'll look forward to hearing what happens over the next 6 to 12 months. Thank you both very much for joining us.
Thank you.
Well, that brings us to the end of another fantastic day at the annual EAU Congress. And in fact, that's all from us at EAU TV for another year. We've had a fantastic time delving into issues around the bladder, prostate, kidney, and much, much more. So who knows what's in store for us next year? Surely more information about the latest surgical techniques and new therapies. Until then, stay in touch, keep watching, and we'll see you next year.